This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffy, who is a paramedic and communications professor.
Today, we're diving into something every single one of us in the field needs to know. The American Heart Association has just released its 2025 guidelines for CPR and emergency cardiovascular care. And this is the first major update since 2020. It brings significant changes on how we handle everything from choking to the opioid overdoses to the very structure of our cardiac arrest responses. So to help us break all this down, we have a very special guest that needs no real introduction, but deserves one anyway. We have today popular social media paramedic and powerful voice in our community, Jimmy Apple. Jimmy, thanks for being here. Welcome.
Absolutely. Thanks for having me.
The way it works is the American Heart Association gives money to scientists through grants and fellowships, so new ideas can be tested in labs, hospitals, and real-world kinds of settings. And the American Heart Association also builds large research teams, and they do that across different hospitals and universities to focus on big problems like heart failure, stroke, high blood pressure, and health differences among communities. Now, the American Heart Association has a journal called Circulation, where it released all of the 2025 guidelines in sections. And they did that in as different journal articles. And so each one is set up to describe the reinforcement or the change of a principle. And then they follow that by a list of research studies. Sometimes I saw like 4 or maybe 10 research studies that contributed to that decision. And each section of the 2025 ALS guidelines underwent this rigorous review by subject matter experts and independent peer reviewers. I know that many of us have felt a shock when it comes to some of the newest changes. And we must remember that in medical science, we rely on the most current research to informed care. This is also why we get frequent continuing education in emergency medicine, because the standards change. So today, we're going to tackle the implementation side of research. We'll group some of these recommendations into 4 different themes. So let's get right to it. Our first theme is systems of care and field operations. And the big shift in 2025 guidelines is to treat out-of-hospital cardiac arrest on scene rather than rushing to the hospital. And this recommendation, based on large observational and registry studies, is work towards sustained ROSC on scene and only transport in special circumstances. So if you can fix the problem immediately, then fix it, is the summary there. And research shows that moving a patient while doing CPR lowers compression quality, increases danger for crews, and doesn't improve outcomes. And so because of this, agencies should be ready to end resuscitation on scene when appropriate and should train crews on how to deliver compassionate death notifications, because this is a major culture change for some systems. And we've already been moving from this scoop and run to stay and play. And these guidelines make that standard sort of more formalized, right? So to make on-scene care work, the guidelines call for having an ALS level clinician present and a team that's big enough for clear, discrete roles. And so studies show outcomes improve when teams are properly staffed and trained, both in and out of the hospital. Another update is about learning from cases. Agencies should use both immediate, hot type of debriefs right after the call, and then another delayed kind of cold debrief later. And so each kind of format catches different issues and helps systems improve. And the community response matters as well, because laws and programs that expand Narcan access are linked to lower overdose deaths. And so the guidelines now support public policies that push Narcan, also known as naloxone, in the community right alongside AEDs. And for dispatchers, the instructions are now simpler and clear that we coach lay rescuers to use hands-only CPR for adults and conventional CPR with breaths for children. So, Jimmy, gosh, that is a lot to process in just our first theme. And I have a few questions for you. And it's really about this. And I want to get an idea from you. How do you see this reinforced commitment to on-scene resuscitation changing a crew's playbook, especially when it comes to managing the scene and interacting with bystanders? This is a new way of looking at care.
So this is a paradigm change. It's not a huge paradigm change. We've been making progress in getting providers to understand that working a patient on scene results in significantly higher rates of neurologically intact survival. In fact, generally speaking, you can expect survival to double by working on scene. There is a lot to process as far as what they are expecting the average crosscut of EMS services to do. I don't think it's a huge ask to have them to work on scene. I think that, though, something that the AHA is not considering when they're talking about hot debriefs and cold debriefs is that it's the old adage, if you've seen one EMS service, you've seen exactly one EMS service. And so there's going to be services that they will grudgingly work on scene, even though there's going to be a contingent of those providers who think that the existence of doctors in proximity to that patient is going to infer a survival benefit to them. And then there's going to be people who are, or services that are on the other end of the spectrum that don't even consider the AHA when it comes to their resuscitation practices. And their motto is that, ACLS gets you exactly 8% survival. So, the AHA is catching up to the high performance CPR paradigm and dragging some of the farther behind services kicking and screaming behind them. And so there is a lot of real estate in there to work with. Speaking for me personally, about 3 years ago, when I launched my TikTok channel, I talked about working patients on scene, and I woke up the next morning to people with pitchforks and torches at my door. And now if I say that, people don't bat an eye. And so that paradigm really is catching up to us now. Where you have to make some progress there is with just some mindsets and some cognitive roadblocks. One of them being, of course, what we would call the resuscitation fairy, which is what is at the hospital that magically improves survival. If you transport, we have to get out of the mindset that the resuscitation fairy exists. We have to get better at death notifications. That is a huge thing, and something that was mentioned in the new recommendations was about compassionate death notifications. And there's some people out there doing good work and attempting to educate EMS providers on compassionate death notifications, Alex Jobber being one of them. As far as scene management goes, there is a huge hurdle in getting people to concede that family members will accept this. And they will accept it, and they have accepted it. But there is a number of providers who they haven't gotten there yet. They don't think family members will accept it. And so they have in their mind this construct of the violent scene of family members attacking EMS crews. And there are places where you're going to go where the notion of you not transporting that patient's family member is going to create an unsafe environment, and you really have no choice other than to get the patient out of there and get moving for your own safety. However, that is not nearly as frequent as people make it out to be. I think most people are conflating upset family members with violent family members, and more often than not, when you have someone, and this comes down to your team configuration, when you have someone that is actually interfacing with the family members, and that is their role, we find kind of what the Joker says in The Dark Knight to be true, that nobody panics when everything goes according to plan. And when you tell the family the plan, they tend to not panic. Hey, we are going to stay here because this is your mother, your father's, your sons, your daughters, your sister, your brother's best chance at survival is for us to stay right here and do everything that the emergency room would do right here. Because if we get moving, everything that we're doing will be less effective. Family members embrace that, and now they're rooting for you. So it's really about getting providers past that cognitive barrier and their own hesitancy.
Yeah, and
And I'll
so
also I'll also add that you also mentioned not transporting and focusing on sustained ROSC. That's where we still have some progress to make, is ensuring that simply because you've gotten a pulse back, that doesn't mean it's time to scoop the patient up and get moving. We need to establish that that patient can maintain that before you just disrupt everything and get going.
well, gosh, I've been writing about this over 20 years ago. I wrote about this, and it's the public perception. And I love a lot of the cool stuff that makes people desire the job that we have that's out there in media. But the truth is that, like we were mentioning, scoop and run is not there anymore. And so my idea is that I think in some cases, we might have the physician on the phone explaining to the family, because sometimes it might require that level of explanation so that the folks that are there can see from the doctor that's going to receive them or whoever the, person would be. I think that might provide an extra level of help. The other all the other things that we talked about were the death notifications, and I want to mention that the First Responder Behavioral Health Institute has a free training program on that topic, and so like you had mentioned, there's a lot of good stuff out there. So in general, I guess we do have a lot to say about this topic, right?
It is almost a whole new world that's opening for a lot of providers when it comes to resuscitation, and it involves more than the physical tasks. And this is where the EMS paradigm is really changing, in that it takes somebody who is skilled more so in just being able to push up and down, being able to squeeze a bag, being able to push a plunger. You need to be able to communicate effectively. And that is a huge tool in our toolbox. I like the idea of having the family interface with online medical control. That would take a lot of coordination between a team and the hospital, probably actually notifying them that you're on the way to a cardiac arrest and making sure that a physician can be available quickly. I mean, I've called for orders to terminate, or, to request, I don't know, something specific during a resuscitation. And, it's taken 5-10 minutes to get a hold of a physician. So
Yeah.
yeah, it would take a lot of coordination, but I do like that idea. It's another tool in your toolbox, another resource on your side.
Well, it of course depends on the system because I've worked in systems where you can, at the snap of a finger, get a physician, on the phone or on scene or on a, different, there's different ways out there. But I think that the emergency physicians understand that at that very moment, we need to be starting the IV. We need to be, and so their role might be, that helping in that communication. Of course, that's my area is communication. And that's one of the reasons why I'm so appreciative of these changes because there's some understanding that all of this plays a role. And so let's move on to our second theme, which is adult advanced life support and post-cardiac arrest care. So the new research here fine-tunes what we do in the first few minutes and then right after ROSC. And so for vascular access, we start with an IV. IO is still a solid backup, but recent large studies and 2025 meta-analysis all show that we have lower odds of sustained ROSC with IO compared to IV. So IV comes first whenever feasible. And in those first minutes of a shockable arrest, we give epinephrine only after the initial defib attempts have failed. So the priority is high quality CPR and the shocks as soon as you can get them on, as soon as you can get the pads on. And the guidance also confirms that vasopressin does not add benefit necessarily over epinephrine. Also, mechanical CPR devices should not be used routinely because studies have not shown a survival advantage. They can be considered in specific situations where manual compressions are hard to do or unsafe for rescuers, but only if it's possible to keep pauses for the device deployment to an absolute minimum. For when to stop, the guidelines support using the universal termination of resuscitation rule in tiered EMS systems. So patients who do get ROSC target a mean arterial pressure of at least 65 because multiple trials show there's no real added benefit from higher targets. So, gosh, Jimmy, time for you to take on these ALS updates. First, will this new data that shows IV preference, is this going to nudge you to push harder on the IV before pushing the IO?
No.
Tell me more about how you operationalize this now that we're back to this new thinking.
The I the data that the AHA is relying on. I mean, I understand that systematic reviews and meta-analyses are the highest form of evidence on the hierarchy of evidence, but those systematic reviews and meta-analyses are only as good as the data that it's covering. So we have to cover a little bit of history of the research that we have on IO versus IV or IV versus IO and cardiac arrest. So our first initial data sets that came in on this showed significantly higher survival rates with patients with IV access as opposed to IO access. However, these data sets were coming in at a time where IV was the dominant access in cardiac arrest, and IO was seen only as a backup route for failed IV attempts. And so after critical analyses of these papers, it was understood generally by everyone that it was just these really sick patients that were getting IOs. And so they were just less likely to survive overall. They were in a poor state of health to begin with. And then since then, we've had some other papers that were kind of like retrospective in nature, not anything that were large RCTs. The only good data that we have on this, the only well-designed large RCT that we have on this is the Paramedic 3 trial from a year or two ago that came out of the UK, which compared survival, including neurologically intact survival, ROSC and everything when it came to IV versus IO, and there was no statistical difference. And it established the fact that IO was a legitimate first-line route. And that is really the only strong data that we have that speaks to this. Also consider that we have data that demonstrates that from time of EMS arrival to time of delivery of epinephrine to central circulation, that IO is significantly faster and first pass success rates are significantly higher with IO. And I think that there is no case to be made that IV is actually superior than IO in that regard, particularly when the survival benefits of the medications that are going through that are at least negligible. So I think that maybe if you're a team that's coming in with 6, 7, 8, 9 people, that sure, maybe you could consider getting an IV access first. Even then, I would advise just drill, and then a team member can be working on an IV, but go ahead and drill. But you come in with maybe 2 or 3 people, you shouldn't be. If you don't see a rope on that patient's arm, then you should be considering IO. Now, there's
Because we're
a
talking
lot
about
of
resources.
that's right. Well,
And we also
resources
recognize we're in
and
dark
benefit.
light and no telling what situation that you're at in the floor behind someone's bed. And so, yeah, they're all obviously going to be resources. And I guess they're just saying that, hey, try for IV first. And if you can't, IO is still cool.
Well, yeah, and what I would say is that this is antithetical to the AHA's mission, actually, because they have worked so hard to streamline this process, right? You mentioned vasopressin. They
Yeah.
got rid of vasopressin because it didn't infer a survival benefit, and they wanted, despite the fact that it bought you 10 minutes of not having to think about a second epinephrine, um, they got rid of it because it streamlined the process. Well, if you are a team with 4 personnel and you have all these priorities, and you look at a patient and you don't see anything that you can get, now you are wasting resources, and your process has become unstreamlined. So I think that in the spirit of streamlining your process, that you should actually be considering IO as a first line, unless you are just, filled with confidence over what that patient is presenting with.
You touched on this already, but I want to ask you more about what you personally feel about the CPR device. I saw your TikTok where you were carrying the device and running and telling them that you would take it from my, dead, cold, dead hands. It was hilarious. And so I love it too. I am here to tell you that I have seen patients live because of it. I mean, I feel like I'm in church right now, being a witness, but I just want you to know I have resuscitated many patients because of it. And so I'm not to saying that if we did the manual chest compressions, it would have been different, but I just want to mention that we do know that it is a help. And I kind of liken it to right now in my head to back when we gave high dose epi and we saw people that converted and lived until we got back to the station and then died in the ICU. And now I'm not sure that this is obviously not quite that aggressive, but I'm thinking about it in comparison sakes. Nonetheless, I saw your TikTok on it. Tell me what you're thinking.
So let me just say one thing. To say that somebody survived because of mechanical CPR, they survived because of CPR, right?
Correct. Thank you. Yeah.
There's multiple ways to perform CPR. You can perform manual CPR and mechanical CPR. The HA is saying that they don't prioritize it because it doesn't infer a survival benefit, but it is a very powerful utility. And so I think that they dropped the ball here. I think that there should be an acknowledgement that we are not unringing this bell when it comes to mechanical CPR. When you have 2 to 3 people show up on a code, you cannot run a 30-minute resuscitation with only those 3 people doing CPR. They are going to be done in less than 10 minutes.
Yes.
And if you're performing compressions properly, everyone should be rotating and giving themselves break, but still they're going to be exhausted. You have 2 people that show up on a scene, you work in some rural area, you're just not going to run a good resuscitation without that mechanical CPR. And so I think that the people in the field are driving this paradigm. They have made it very clear that this is a utility that they are not giving up simply because of the fact that it does something that is exhausting to them. And so we are not going back. Now, to services that have a large number of providers and who are familiar with the data that come out of systems that perform high performance CPR and who have a commitment to, high quality resuscitations and a commitment to the data, they probably can be talked out of prioritizing CPR. In fact, they would actually need to be talked into prioritizing it. Seattle attempted to incorporate the Lucas, and to quote one of the people that I talked to who were involved in a resuscitation academy, they just wanted to go throw them all in the trash. Tom Boothele with Hilton Head Fire Department incorporated high performance CPR, and their resuscitation rates went through the roof. They tried to incorporate the Lucas, and immediately it just gimped their survival rates. And there could be there could be a training issue there, but there is room for a lot more improvement with manual CPR than there is for mechanical CPR. Mechanical CPR is doing only exactly what it is designed to do, which is to just push up and down.
Yeah.
And it may not be pushing up and down in the exact right place. And it may be tilted backwards. It may be tilted forwards. It may be wandering. It may be over the left ventricular outflow tract. And it has a very small margin for error when it comes to that piston. Whereas if I'm performing compressions, I have these two hands here pressed on your chest. And even if I'm not quite in the right place, I still have kind of a plate-sized object that's pushing down on your chest. So I think there's a greater margin for error with hands, and there is a lot more room for you to improve and continue to do better. In fact, I know that
Yeah.
Austin Travis County actually did a study where they compared outcomes to a strategic use of mechanical CPR. They came up with a plan for placing it quickly, and um, their survival rates dropped with the use of the Lucas as compared to high performance CPR. So just like everything else is situational, but it is a valuable utility for many people, even for an on-scene resuscitation, and it's not going away.
Yeah, and I can tell you that I appreciate it because it allows everyone to be able to think clearly and not have to do an extra adrenaline physical activity on top of the calm thinking and communicating that we need to be trying to do. And I've used it a lot. I've done a lot of resuscitations with it, and I can tell you that it's fantastic with only two things. And if you know how to manage those two things, then I don't think it'll ever be a problem. One is making sure that the battery is charged and ready to go, and the second thing is that you do the placement right, because it does not fit on large people. And don't even try. No reason to try. Waste time. And it has to be positioned correctly, because um, the body might move just a little bit and require that repositioning. So you just have to keep an eye on it. But um, my goodness, I've seen the development of them all the way through now. I've been seeing them in emergency rooms around Houston. So it's something that they've even put in the hospital. So I'm curious as to see what hospital systems are going to do, because they don't have the same resource need demand that we do. But it's
They don't,
really
and they don't
interesting
have the
role.
same commitment to training when it comes to resuscitation. And I don't mean, and I'm not disparaging hospitals. They have, particularly like emergency rooms and ICUs and stuff. They have to be, you know,
Perfect. Yeah.
they have to be responsible for knowing and doing a lot of things, whereas EMS can focus in a little bit more on some very specific things. Like EMS owns resuscitations for sure. I don't think anybody would argue with that. In hospital survival rates with the use of mechanical CPR, according to data, is lower. And that's most likely has to do with the fact that they just don't train on the devices the way that EMS trains with the devices. I would really like to see another RCT when it comes to mechanical CPR, considering as much training as we've done with these devices now. A lot of this data that we're working with in mechanical CPR is a lot older, and some of the data comes from in-hospital use. There's some people that think that it all comes from in-hospital use, but that is absolutely false. There's plenty of data that comes from the field, but I would like to see data uh, comparing the use of mechanical CPR to manual CPR with a properly trained crew, a large RCT.
Well, I agree. Don't take it away.
Yeah.
But now let's move on to our third theme. We're talking about pediatric and neonatal updates for EMS. And the headline in pediatric BLS is to minimize interruptions during CPR. Registry data shows that more and longer pauses, the lower the chance of ROSC. So keep pauses under 10 seconds. For infant compressions, the old two-finger technique is no longer recommended based on simulation and observational studies. So we now use the heel of one hand or the two thumb encircling hands technique instead. There are important challenges to think about when we look at how choking is a new protocol. For children, we do repeated cycles of 5 back blows followed by 5 abdominal thrusts until the object comes out or the child becomes unresponsive. For infants, we do repeated cycles of 5 back blows and 5 chest thrusts. For children, starting with back blows is sort of a change from prior teaching. In pediatric ALS, we give epinephrine as early as possible to those non-shockable rhythms. If there is an invasive airway in place, then we really look at entitled CO2 monitoring to monitor the CPR quality. We know that values of 20 and higher are associated with better outcomes, but don't use any single entitled number by itself to really decide when to stop resuscitation. It's just consideration. And if an arterial line is present, the guideline now is to include the diastolic blood pressure targets so that we could guide care. In a neonatal care EMS setting, ventilation comes first. It always has, really. And we place the pulse ox on as soon as possible whenever providing respiratory support. So in pediatric, non-shockable arrest, Jimmy, what does early epinephrine look like operationally on the ambulance? What barriers do you anticipate? So it's kind of like, do we have it drawn up ready before we walk in the door?
Yeah.
What are your thoughts?
Well, I'll let you in on a little secret when it comes to EMS and epinephrine, which is in reality, yeah, when the EMS team arrives on scene, I don't think people are considering the administration of epinephrine and the timing that ACLS recommends. I mean, people are just doing, it's kind of like the movie title, Everything Everywhere All at Once.
Yeah.
That's kind of what's happening. And so if you get a crew of, between 5, 6, 7, 8 people on scene, epinephrine is getting in very quickly because somebody has been assigned the role to get access. Somebody's drawing up medications and handing them out. And so epinephrine could be in within a minute or two, even though it may not at one point, depending on whether you're an adult or pediatric, it may not have actually been indicated even yet. You may not have defibrillated yet or anything, but it just goes in because cardiac arrest. But if there's a crew that has only 2 or 3 people, their priorities are going to be starting compressions and ventilating, and the getting the IO or the IV is a secondary consideration, and that's not even with the considerations of the challenges of getting access on a pediatric. I mean, even IO access can be challenging on a pediatric, depending on how old they are, which is why distal femur is starting to become a great route because it's a really solid area to get on them. But in reality, the logistical challenges are just time to task challenges. So, getting IV access, getting IO access, drawing up medications. And so this is why we're starting to see studies with IM administration of epinephrine, not only in pediatrics, but adults. And we're seeing that this could be a very viable route, particularly for resource-starved teams, where you just come in and even the person starting compressions can just kneel by the patient, jam a needle in their thigh,
I
and
thought
then
you were going to say heart.
yeah, well, that would be super cool, kind of like Pulp Fiction style.
Yeah.
But jam a needle in their thigh, and then they can get right to compressions with almost no delay. And if, I think we probably will get to a place where we're going to be doing epinephrine auto injectors, because I think you're going to see a greater emphasis on earlier epinephrine all around and not just in pediatrics.
I agree. That was what I was thinking too, about these easier ways to access the medication based on, well, the weight of the patient. And so it's sort of like, I could imagine that you would be able to do the Braille tape, pick the color, and based on that drawer, have pre-drawn meds in that cart for that. Because right now they're not pre-drawn. Usually they're just like the whole box there. Do you have a first 5 minute kind of thought about how things are going to go for your team?
And a pediatric arrest?
Yeah.
Yeah. Well, I mean, the biggest tweaks are going to be having video laryngoscopy. I mean, that's super important for adults, but it's super important for pediatrics as well. People tend to intubate a pediatric. I mean, some people have never done it in their career. In a decade, maybe somebody might not have intubated a pediatric patient. I mean, I do right now full-time neonatal and pediatric critical care. And so, I do that regularly. But, prior to getting into that, it probably had been a decade since I had intubated someone, who was younger than, say, 10. So having video laryngoscopy is a huge cognitive offload just to have, I mean, even just for your confidence of knowing that you can actually just see in there rather than struggling to do the manual and struggle with the anatomy and the unfamiliarity with this, with the size of the anatomy. I think that makes a huge difference. consideration even of early SGAs if either you don't have video laryngoscopy or you have an established competency in adult intubation, let alone pediatric intubation. But I think overall, I think we're also going to see an emphasis on SGAs simply as an airway, an immediate airway adjunct. And it
Mhm.
doesn't preclude intubation later, but something that we have to consider is that we're ventilating these patients, and in many cases, we're not using manometers and we have no idea the pressures that we're using. And so on these patients, both adults and pediatrics, if you exceed, 22, 23 millimeters of mercury, that's the critical opening pressure for the gastric sphincter.
Mhm.
And that's the path of least resistance. And so, and it's very easy to fully inflate pediatric stomachs.
Mhm.
You're not working with a whole lot of volume there. And so now that's impeding on intrathoracic pressure in both adults and pediatrics, but that can become a problem very quickly for pediatrics. And so I think that even on pediatrics, kind of the early SGA, we might start seeing that happen too. I mean, we've kind of accepted as a paradigm in adults. I think you might start seeing that trend down towards pediatrics as well, so we can better manage that gastric insufflation.
And so, from what I understand of my reading so far, these ACLS changes are basically saying that we ventilate to see chest rise. As soon as the chest rise, you're done, right? So that's basically, I think, how
There is
they're handling it right
no
now.
correlation to chest rise and adequate tidal volumes. That is not data driven. You should be using some sort of device at this point that's telling you the tidal volume that you're delivering, or using a device that cannot deliver excessive tidal volumes and or pressures.
So tell me more about that with infants. How is that?
Well,
Because we have a bag valve mask, and we know that that's what we're putting in right then, right? We know that that's the two, whatever the 100 C.
sure. I mean, there are bag valve masks out there now. The butterfly bag valve mask is one of them. They were demonstrating that at EMS World, that you can actually set your tidal volume. And so you can set it for neonates, infants, toddlers, that sort of thing, to make sure that you don't exceed the appropriate tidal volume. But then there's also devices, small devices that you can put in line with your BBM and your advanced airway device that will tell you the tidal volume that you're delivering. So, in fact, the Zoll, I don't know if it's the current monitor or the one that's coming, the Xenix. I think the X series had this now, that they have tidal volume guidance as well. So and when half, I don't know what Zoll's market share, but you know they're really catching up to Stryker, and you have that technology right there. We should be using some sort of technology to actually guide our tidal volume.
What we see is people talking about, it used to be, how nice is the ambulance when you wanted to go work somewhere, and then it was moved on to, well, how do the protocols match up, or do they allow you to um, do your job when you need to, or do they allow you to think on your own? And now I think we're looking at stuff like this, these really cool tools that we see might be able to make a big difference, especially because now they help with quantifying things that help us understand these different aspects of CPR. Well, now we're on to our final theme, which is really the special circumstances. And we're going to talk about airway management, LVADs, pregnancy, and some opioid related care. And the choking update in kids now also applies to adults. So for a severe airway obstruction, we do repeated cycles of 5 back blows followed by 5 abdominal thrusts. These observational studies suggest that this approach clears the blockage more often and causes fewer injuries than the abdominal thrusts alone. So use chest thrusts instead of abdominal thrusts in late pregnancy or whenever you can't safely get around the abdomen. For the patients with a LVAD who are unresponsive and show that they don't have good perfusion, we do now start chest compressions right away. So the LVAD is a left ventricular assist device, and it's whether it's pumping or not at this point, whether it causes trauma or not at this point, we are going to prioritize making sure that perfusion happens because we're thinking that while one rescuer begins compressions, the second rescuer should check the device for alarms, for power, the connections. And so the balance of a risk and benefit favors restoring perfusion fast. For cardiac arrest in pregnancy, we prepare for a resuscitative delivery as soon as an arrest is recognized. And the goal is to complete that delivery by 5 minutes. So that's the emergency, that's the new emergency ideal. Finally, for opioid related emergencies in suspected opioid associated cardiac arrest, giving Narcan or naloxone may be reasonable as long as it doesn't delay or interfere with high quality CPR and providing breaths. So that's still where the focus is getting the patient's blood moving and oxygen in there. So the evidence for Narcan in true cardiac arrest is sort of mixed, but its benefit in respiratory arrest from overdose is obviously clear. Patients treated for overdose should also receive leave behind Narcan and instructions on how to use it. And that's all part of the new guidelines. Jimmy, talk to me about this. What message do you have to your teams who have these kinds of devices?
Well, as far as the LVAD goes, you know, pump, baby, pump.
Yeah.
If your patient is, I'm going to say, if your patient is pulseless, but your LVAD patient probably is going to be pulseless, even if they're just standing there talking to you, because it doesn't generate a pulse. But if you believe that your patient is not perfusing, you have no evidence of perfusion through whatever diagnostics that you have, and the patient's mental status or level of consciousness or whatever, then you should be performing compressions.
Hmm.
There was a fear instilled in providers, more than a decade and beyond that ago about performing compressions in LVAD patients. The fear was that it would dislodge the device. However, multiple observational studies have failed to produce a dislodged LVAD from chest compressions. And there's even a case study of a patient that received mechanical CPR with the Lucas device, not a compression band system like the Autopulse, but with a piston device for hours. And it didn't dislodge the device and it didn't damage the device. And so you should have absolutely no hesitation about performing chest compressions in someone with an LVAD if you don't think that they're perfusing.
Yeah.
None whatsoever.
And I've been in this situation before, and it's a very stressful moment to look at the monitor and look at the patient and realize that you are not sure if this is PEA or not, but they are not perfusing, right? And skin color, level of consciousness, those kinds of things are indicated, and I indicating that, and I know that for a while we were just looking at basically doing chemical codes on these folks with the extreme concern that these, things would be dislodged. But like you said, I haven't heard of a case of something like that happening. So
Yeah. And there's another word for a chemical code, which is not a code.
I know. Yeah.
Yeah, right.
Yeah.
The notion that okay, we'll just dump some epinephrine in there and just pray, it would, even if half of your patients had a dislodged LVAD, I think that you know uh, uh, it's still better than nothing. Uh,
Yeah.
I probably shouldn't say that, but I would think that even if there's a risk of dislodging the tube, there's a greater risk of not doing anything at all. And this is one of the things where actually having something like point of care ultrasound on that truck can help you with as well. Start compressions, but then you can look and see if there's actual cardiac wall motion or not.
Yeah, and that actually pushes right back to where they're saying if we have an intervention that we can make, if we can figure out of the H's and T's we need to where we need to make an intervention, then do it right then. So that is another tool that gives us that.
Right.
And speaking of technology, I was at UTMB Galveston for a conference learning about some different types of heart lung machines, and these eCPR machines, or some go directly into the vein, some go into the artery and pump oxygenated blood for the patient. And so they were talking about some of these same statistics about, how well that these folks are doing. And so for a pregnant patient that is in an arrest, I I'd end up at a point where I wouldn't even know who to call first, right? Because do
Sure.
you want to get that neonatal team down to the ER, or are you going to make sure they get a surgical suite? Like, I mean, I am just trying to imagine through what this is going to look like in hospitals to implement this, because in my mind that means that this is a surgical team response. So tell me
Yeah.
how you feel like this is going to go down.
Well, so we have to break this down into two different paradigms. There's the in-hospital paradigm and the out-of-hospital
Hmm.
paradigm, right? With an out-of-hospital paradigm, a pregnancy is a huge, huge complication to actual cardiac perfusion. Like you cannot,
Hmm.
like you're getting past like the 20-week mark, you cannot adequately perfuse the mother's heart with
Hmm.
CPR because there's too much fetal blood volume, which is why we're starting to see a lot of attention paid to what's called the resuscitative hysterotomy, where they essentially perform a salvage operation on scene and just brutally surgically remove the fetus in order to reestablish maternal circulation. If you aren't a minute or two from the hospital, the odds are overwhelmingly, and you're not able to perform a resuscitative hysterotomy, the odds are overwhelmingly against maternal survival. And even considering the fact that they have eCPR, if you can't like literally just like if you were an EMS crew that was just in the ambulance bay, and there was a maternal arrest that happened right in front of you, and you were able to just drag her into the room where they have the ECMO machine set up and they can perform eCPR, the odds are overwhelmingly against a good outcome there. So, um, it would probably make more sense for services to consider, either allowing a well-trained crew to perform a resuscitative hysterotomy or to have someone who can get to the scene quickly from the hospital to perform a resuscitative hysterotomy rather than to consider, like activating ECMO. Um, yeah.
And of course, we know that the studies that I just mentioned were for patients that were already in the hospital.
Yes.
So it was just a matter of like, telling the crew, okay, let's do it. But for us, yeah, it's not the same. And I know it's a scary thing to imagine doing that procedure in the field. And I know that it's been questioned as something that we're not qualified for. And even though I've delivered babies, that's definitely out of my, C-section's out of my scope. But that doesn't mean that I couldn't learn, and it doesn't mean that it might not actually save lives.
Yeah. I mean, I'm not unaware that the notion of empowering your field paramedics to perform something that invasive and brutal is a huge ask. That's not lost on me. I mean, I don't think we're going to see widespread implementation of the resuscitative hysterotomy.
Not yet. So overall, with all of these changes and everything going on, I want to give you the last word and to share your thoughts.
The only two interventions known to improve survival in out-of-hospital cardiac arrest is timely defibrillation and quality compressions. Everything else is window dressing if you don't actually focus on those two things first.
Yeah, and my highlight of this is that I appreciate the fact that they are letting us think like clinicians and work through the H's and T's as a priority. It's not like they haven't always been there, but survivability is better and better as things continue to develop. So, Jimmy, thank you so much for breaking down this dense but incredibly important 2025 AHA guidelines with us today. I just wanted to say that your perspective from the field is what makes this information real and usable for us.
Thank you. I appreciate it. Thanks for having me here.
Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah, and right. And you think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chaplot from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for you to review on our website at iphmi.com. and also published through GEMS Online Magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field or what we should be doing in the field or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here. And all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials. Relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call.
go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.